This is Professor Nilanjan Sengupta, Professor and Head Department of Endocrinology in Aras Medical College. Today I will be taking you through a case of newly diagnosed type 2 diabetes and how really we should go about tackling the hyperglycemia and address the risk factors in such a patient. This is the story of a 45-year-old gentleman who has newly been diagnosed to be suffering from type 2 diabetes, visited the clinic of the endocrinologist around 6 months back with multiple risk factors like obesity, essential hypertension, and dyslipidemia. Not uncommon to find in such a patient because there is a constellation of these risk factors in a patient with diabetes and metabolic syndrome. He was initiated with metformin as per standard protocol with advice for lifestyle modification, which included diet as well as exercise and also avoidance of tobacco because he was using oral tobacco too. Tobacco in all forms should be discouraged. Not only smoking, but tobacco consumption in all forms should be discouraged. He has come again for visit as a part of the routine checkup. And now these are the laboratory parameters which I enumerate. He is at present having an A1C of 8.5%, an EGFR of 80 mils per minute, LDL cholesterol 80 milligram per deciliter, a low HDL in 38 milligram per deciliter, and a slight mild hypertriglyceridemia in the form of 200 milligram per deciliter if you take 150 to be the cutoff of normalcy. As I have told you, is on 2 gram of metformin daily with lisinopril, metoprolol, 40 milligram of atorvastatin, and aspirin. So we can understand there has been attempt at controlling the hypertension, maybe microalbuminuria too. Statin has been used to take care of the lipids and atherosclerosis, and an antiplatelet agent is there as per standard of care. Not too bad. Currently, his BMI is 31 kilogram per meter squared, meaning he is still obese. Blood pressure is well controlled under therapy, 120 by 70 millimeter of mercury, heart rate around 80 beats per minute. So what next to do? A patient who is uncontrolled on metformin, having other risk factors, it naturally goes without saying the anti-hyperglycemic therapy has to be up-titrated, has to be intensified. How do we go about intensifying that? That would be our point of discussion today. Now, evidence indicates that early intervention and achievement of glycemic control reduces the risk of long-term microvascular and macrovascular complications, as with the 10-year follow-up of UKPDS in type 2 diabetes, as well as in the DCCT-ED. What is actually known as the metabolic memory or legacy effect. The better you achieve glycemic control from the very day one in a life of diabetic patient, in this case a type 2 diabetes, the better would be the ultimate outcome so far as micro and macrovascular disease is concerned. So keeping this in mind, I think at this point of time, in a 45-year-old gentleman, we would never ever be satisfied with a glycated hemoglobin of 8.5%, and I would love the glycated hemoglobin to be under 6.5. So if we want to bring it down by 2 percentage points, previously what we used to do, a step care approach, that is uncontrolled on metformin in an obese patient, we would have added a sulfonylurea and wait for another couple of months, up titrate the dose of sulfonylurea, maybe 1 milligram of glimepiride, 2, 3, and 4, and then think of adding another agent. But now we are not using sulfonylureas that much as a first add-on. Maybe we are keeping it reserved as the third or fourth add-on. And now the space of sulfonylurea has been taken over by the DPP-4 inhibitors and probably even more recently by the SGLT2 inhibitors. Now, this patient has hypertension, this patient is obese, has dyslipidemia, so he has definite multiple risk factors for coronary artery disease, as well as he is obese. His EGFR is just little under 90 mils per minute, not too bad. But I think now, what would you rather use to intensify the therapy? First thing, whether you would go by the stepped care approach or be more aggressive. I think we can be now more aggressive rather than following the stepped care approach, because if we follow the stepped care approach, it would take about a year or so to bring the glycated hemoglobin down by 2 percentage points, if ever that is achieved. But if you want to bring it down by around 6 months' time, I think the best approach would be to give a combination therapy of 2 oral anti-diabetic agents. I think at this point of time, nobody would love to use a sulfonylurea, though it would be efficacious in the short term, but it can actually add to the weight gain and will not give very many cardiovascular protection. So I think if we have to think a combination therapy at this stage, when a patient is uncontrolled on metformin monotherapy, a good combination would be a DPP-4 inhibitor, SGLT2 inhibitor combination. Why do I say this? Because with this combination, we have the least chance of developing hypoglycemia, no matter how aggressive we go. That is one advantage. Second, while a DPP-4 inhibitor like sitagliptin, vildagliptin, or linagliptin is weight neutral, an SGLT2 inhibitor like canagliflozin, empagliflozin, or dapagliflozin can indeed also lead to weight loss. So a combination like an EMPA-LINA combination, that is empagliflozin, linagliptin combination, that is linagliptin in a fixed dose of 5 milligram per day, and empagliflozin in a dose of either 10 milligram per day, which you can up titrate to 25 milligram per day. Whether you give it in a separate pill or a fixed dose combination, probably will be able to bring down the glycated hemoglobin to at least less than 7%, and with a good lifestyle modification may even be able to bring it down to less than 6.5% when added to metformin. They are weight neutral, or you may even get the weight loss benefits of SGLT2 inhibitor like empagliflozin manifest with this combination. The combination may have protective effect against heart failure, against a cardiovascular event, and also cardiovascular mortality, as has been elucidated from the very beautiful EMPA-REG outcome trial. Not only that, the EMPA kidney study results is yet to be published in full, but still there is an indication with empagliflozin there may be some degree of renal protection in the form of decrease in the albuminuria grades and decrease in the necessity for renal replacement therapy, as has been very well elucidated by the DAPA kidney trial and is expected to be replicated with empagliflozin too. So I think in this patient, intensification of therapy with an EMPA-LINA combination. Now, again, I say whether you use a fixed dose combination or use them separately, that may be your choice. but the fixed dose combination has an advantage of decreasing the pill burden as well as the cost of therapy considerably, maybe around 25 to 30 rupees per day if you give an Empalina combination in a fixed dose than you give the two agents separately. Studies have shown that with such a combination, there may be around 1.8 percentage point reduction in glycated hemoglobin with a starting baseline glycated hemoglobin more than equal to 8.5% at 24 weeks. So that is a very attractive proposition, and the benefits on glycemic control were maintained up to 52 weeks, meaning the durability of glycemic control with this therapy. Now, sulfonylureas can actually act miraculously in the short term, but the disadvantage of a sulfonylurea-based combination would be, the loss of durability of glycemic control with a single agent and with a tendency to further increase the body weight. So I think here an SGLT2 inhibitor, DPP4 inhibitor combination like an Empalina 1 would be the ideal agent to intensify treatment with. To summarize, therefore, in metformin uncontrolled patients with multiple risk factors of cardiovascular disease or even with established cardiovascular disease, especially if the person is overweight and obese, DPP4 inhibitor, SGLT2 inhibitor combination like an empagliflozin linagliptin combination not only provides robust glycated hemoglobin control over a considerable period of time, but also addresses the multiple risk factors, can also have a beneficial effect on body weight with a very low potential for causing hypoglycemia. So, friends, I think I have told you with an illustrative case how we can actually intensify treatment of type 2 diabetes in a patient who is uncontrolled on metformin monotherapy. And I really thank the scientists all over who have developed this wonderful class of agents like the DPP4 inhibitors and SGLT2 inhibitors through their arduous research so that we clinicians and patients enjoying the benefits of good glycemic control with these agents with the least potentiality for side effects. Thank you. Let's strive towards a diabetes-free India. Good day.